Hello, everybody. Thank you for joining today. Really exciting session. My name is Alan Schroeder from Hospital Medicine and Critical Care, and I co-chair this series with Dr. Raji Matthew from Pediatric Infectious Disease. And today is one of our first sessions on kind of an organ-specific approach to COVID, and we'll be focusing on the heart. And Dr. Tierney will be moderating today's session, and we'll introduce our speakers in just a minute. But before that, just a reminder about the CME credit for that, which will also be placed in the chat function. So don't worry if you don't get it in immediately, but here it is on your left. Next week is going to be our last session for 2020, and it should be an important one. We're going to bring Dr. Maldonado back and put Dr. Matthew in the hot seat as well. And I will moderate that session, which is intended to be an open forum to answer questions for you guys in the community. We'll focus mostly on the vaccine, which of course is a hot topic. We'll try to focus on testing as well, and then maybe a little bit about the current surge and any new updates on transmission and epidemiology. There is a link that you can see here to submit questions in advance, and also we'll put that link in the chat. Please submit your questions. We'll try to consolidate those and get them answered to the best that we can. And then we'll kick off 2021 by another important organ system. You guys can argue for which is more important, but we're going to talk about the brain and the nervous system with a great set of speakers then. Gives me great pleasure to introduce Dr. Bradford Nguyen, who's one of our pediatric chief residents and will be leading today's evidence quick hit. We're talking about a recent article from JAMA Pediatrics just published a couple of days ago, which I think is maybe tangentially linked in some ways to the rest of the session today, but really is an important epidemiologic perspective. And Bradford, as I mentioned, is one of our chief residents and is pursuing a career in hospital medicine. Great choice. Thank you so much, Bradford, for joining us today and presenting.
All right, thank you so much for having me here. It's such a pleasure to be able to get to do this. Again, I'm Bradford, I'm a chief resident. Alan has given me a very strict 5 minutes that I will do my best to follow, so I apologize in advance for speaking very fast. But the article that I am going to review really quickly came out about 2 weeks ago, is the assessment of 135,000 pediatric patients tested for severe acute respiratory syndrome coronavirus 2, SARS-CoV-2, across the United States by Dr. Bailey et al. So the question that this paper was seeking to ask was, what is the epidemiology across the US of SARS-CoV-2 among pediatric patients undergoing testing? As for some background on this study, this was through PedsNet, which is a consortium of 8 different large children's hospitals, 7 of which who participated in this study. These institutions collectively serve 3% of the nation's children annually, so that's 2.5 million patients. And data was extracted up to September 8th of this year for patients younger than 25. So their cohort formation, the positives included anyone with a positive PCR or positive serologic test with no negative PCR. A severe illness in this study was also categorized as patients who were hospitalized within 7 days prior to the testing date, and an inpatient diagnosis of either pneumonia, sepsis, respiratory failure, or a COVID-19 related diagnosis. Excuse me. So some of the results from this paper, what really came out of it was some of the interesting information about demographics. So 3% of the PedsNet population was tested, and 5,374 of those patients, or 4% of them, had tested positive for COVID. A higher proportion of negatives were found among younger patients and those with commercial insurance, as well as those tested inpatient. Of note, they did break down some of their demographics by race. And so Black, Hispanic, and Asian patients were more likely to be positive. And so their odds ratios were 2.66, 3.75, and 2.04 respectively. Of note, this could also be related to the fact that there were lower rates of testing in these populations. So it's possible only the really sick patients were getting tested. And so the odds ratio compared to their white counterparts were 0.70, 0.65, and 0.60 for Black, Hispanic, and Asian populations, respectively. Positive results were also more likely to have undergone testing in the ED and were also more likely to be insured by public insurance programs such as Medicaid. Now, severe illness, I know is something that we're all watching very closely in our hospitals. Of the 5,000 patients who tested positive, 359 of those were met criteria for severe illness, so 7% of them. There was also an associated higher intensive care unit use, so 99 of those 359 patients were in the ICU. These patients also had a slightly increased length of stay. 33 patients, so 9%, required ventilatory support, and then 8 patients with positive test results died, leaving a case fatality rate of 0.2. Of note, 6 of those 8 patients had also had complex pre-existing comorbidities as well. One of the things that was interesting and maybe related to, as we talk about cardiology during the talk today, is sort of their look at Kawasaki disease diagnoses in the last year. And so what they did was they compared it to 2018 and 2019 specifically during the same time frame of that year. And all of the participating institutions saw a decrease in the amount of Kawasaki cases. So there was a 40% decrease in 2020 across all health systems. That's 259 versus 430 in 2019 and 433 in 2018. And then 107 of those patients underwent COVID testing, and 8 of those had positive test results. That's just to say we really can't use Kawasaki as a proxy for MISC, as we're seeing a decrease in rate of the Kawasaki disease that we're seeing. They also take a look at chronic illness. Now, what they did was they calculated a standardized ratio using the number of patients who fell under certain categories through the PMCA criteria or the Pediatric Medical Complexity Algorithm, using numbers from the prior year as the denominator. Patients who fell under those categories in 2018-19 who also had viral illness. And what they saw was that a higher proportion of these patients were testing positive for COVID-19 in these select categories, cardiac included. So we have malignant disorders, cardiac, endocrinologic, GI, genetic, hematologic, MSK, mental health, and metabolic disorders. In summary, I wanted, or the paper really wanted to have these takeaways that SARS-CoV infection rates were low and clinical manifestations were typically mild. And then as previously mentioned, certain populations were affected more. And then Kawasaki disease, again, is not an effective proxy for MISC. So thank you again. I will now wrap up and pass it back to Roshni.
Thank you so much, Bradford, for that excellent presentation. Now we're going to move on to the actual session on COVID and heart. This will be moderated by Dr. Seda Tierney. And so I will introduce Dr. Tierney, and then she will introduce our guest speakers. Dr. Tierney is also part of our COVID-19 in Children Seminar Series committee member. So Dr. Tierney is an associate professor in pediatric cardiology at Stanford. She's also the director of research in non-invasive imaging laboratory and director of pediatric vascular research laboratory. Thank you, Dr. Tierney. I will let you take it from here.
Thank you, Roshni. Well done, Bradford. That was a great review and very fast and effective. Now it's time for our first speaker. It is my distinct pleasure to introduce my brilliant colleague, Dr. Liz Profita. She is a clinical assistant professor in pediatrics at Stanford. She's a pediatric cardiologist specialized in pediatric heart failure and transplant, and she will give us an overview of COVID-19 and myocarditis in children. Liz, the floor is yours.
So I have to start by saying that it was initially supposed to be David Rosenthal who was going to be here talking. He helped put together these slides, and these are very big shoes of his to fill. So please excuse any lapses that I have today. So his disclosures were that our understanding of myocardial disease from SARS-CoV-2 is evolving. And that there really isn't a lot of data about pediatric manifestations. And he said his own knowledge is all from the literature, which means, gosh, I think that's probably true for me too. And obviously these slides are a combination from the two of us. So we're just going to briefly review myocarditis, and then I'm going to talk a little bit about the cardiac involvement in COVID-19 and MISC, and then give an example of a case of COVID myocarditis. So myocarditis is a condition that results in inflammation of the myocardium that is associated with cardiac dysfunction. And the presentation can vary widely from mild with minimal symptoms to severe decompensated heart failure. Half of patients that are hospitalized require inotropes, and about a third can require mechanical ventilation. The majority do survive to hospital discharge, but there is a significant number who develop dilated cardiomyopathy and may require heart transplant. The most common cause is viral in North America, particularly enteroviruses. The World Health Organization and the AHA classify it as an inflammatory cardiomyopathy, but we do see it somewhat distinct from dilated cardiomyopathy. The symptoms can be variable depending on the severity of presentation, but it can present with tachypnea, abdominal pain, vomiting, chest pain, syncope, palpitations, often resting tachycardia, and sometimes more threatening arrhythmias. The ECG can be abnormal with low voltage QRS, some ST or T wave changes, QTC prolongation. You can see some scattered ectopy with PACs and PVCs, and occasionally worse arrhythmias as well. Labs will often show elevated inflammatory markers, including CRP and ESR, along with troponin and BNP. And the echo may show LV dilation or can show normal LV measurements, but usually should have a decrease in your LV ejection fraction. There can be regional wall motion abnormalities, and some patients will present with more of a myopericarditis type picture with pericardial effusions. This graph shows the competing outcomes analysis of patients diagnosed with myocarditis, and you can see that there is a good proportion of patients that present with myocarditis that have normalization of their function, but there is also another significant proportion of patients who may die during their hospitalization or may go on to require heart transplantation. Myocarditis is diagnosed typically via endomyocardial biopsy during a cardiac catheterization, and this is considered to be the gold standard. It is usually considered through the Dallas criteria, which is an inflammatory infiltrate of the myocardium with necrosis, but there is no agreement on the actual quantification of the infiltrate, and some centers will use cardiac MRI for diagnosis as well. So moving over towards COVID-19, so there have been many studies that have described cardiac involvement in COVID-19, both in adults and in pediatrics. And there's some suggestion that the clinical course of COVID-19 can be worse in patients with underlying conditions, including congenital heart disease and heart failure, although there is very, very limited data on this. Some of the cardiac signs and symptoms that have been discussed include tachycardia, abnormal EKGs, elevated troponins, and symptoms of heart failure, which we'll talk more about. And the cardiac involvement can be both primary, as in direct myocardial injury, and secondary from RV failure related to pulmonary involvement. While there is some arrhythmia that's seen, it is less common than what has been reported in adults. The pathophysiology of the cardiac involvement in COVID-19 is somewhat theoretical, but there's multiple different theories. So there is some theory around direct myocardial injury, as the viral RNA can be found in the cardiac myocytes. And we know that SARS-CoV-2 binds to the ACE type 2 receptors on the cell surface and can enter the myocytes that way. And there may be some differences in our patients with heart disease related to the overexpression of the ACE type 2 receptors. Or children may be less susceptible to COVID-19 due to the decreased function of these receptors, but this is isn't well known. And then hypoxemia from pneumonia or lung injury can also lead to metabolic acidosis and oxygen-free radicals that may lead to myocardial injury. It also leads to an inflammatory response that can also lead to myocardial injury through activation of multiple inflammatory cytokines and lymphocyte Th1 activation. And we know this this is supported by the fact that inflammatory markers are often elevated in patients with COVID-19. And so when you get a viral infection, it leads to an immune response that activates your lymphocytes and macrophages that can lead to both thrombosis, as we know that there's a dysregulation of the coagulation system. There can be endotheliitis with large and small vessel disease, and a cytokine storm with multiple inflammatory cytokines. This was an autopsy study of 21 adult-aged patients looking at the pathology of myocardial injury with COVID-19. And most notably, there was diffuse macrophage infiltration in 86% of patients, despite the fact that lymphocytic myocarditis was only found in about 14% of the patients. There was also findings of endocardial thrombosis, focal pericarditis, RV strain, and some small vessel thrombi. So they concluded that myocardial interstitial macrophage infiltration was frequent even in the absence of myocyte injury that we would normally think of with myocarditis. Moving over towards MISC. So as we know, MISC is the multi-system inflammatory syndrome that resembles Kawasaki disease, as Bradford alluded to, that is associated with COVID-19. So in this New England Journal study, they defined MISC as a serious illness leading to hospitalization in patients less than 21 who had a fever greater than 38.0 for at least 24 hours, lab evidence of inflammation, multi-system involvement of at least 2 organ systems, and evidence of SARS-CoV-2 infection in the past month. And so using those inclusion criteria, they looked at 186 children from 50 plus centers, and only a very small percentage, 7% of the patients had what would be thought of to be COVID symptoms prior to being diagnosed with MISC, and the median interval from COVID symptoms to MISC was 25 days. These patients looked a little bit different than Kawasaki disease patients, which are typically a little bit younger. Their median age was 8 years. They were slightly more male predominant at 62%, and the majority were previously healthy, with 73% previously healthy. And the majority had multi-organ system involvement, including cardiac, heme, that should say GI, not IG, and respiratory symptoms. And when we looked at the cardiac involvement for these patients, 80% of the patients had cardiac involvement in these patients that were diagnosed with MISC. That included an elevated troponin in 50% and an elevated BNP in 73% of patients. The majority of these patients did have echocardiograms, but the majority had normal LV function. So 62% of the patients had normal LV function. 33% had sort of mild to moderately decreased function, and only 5% had severe LV systolic dysfunction. In contrast to Kawasaki disease, we weren't seeing a significant dilation of the coronary arteries, and the LAD and RAD Z scores were only greater than 2.5 in 8% of patients. But interestingly, almost 50% of the patients required inotropic support, which would be higher than what you would anticipate given this degree of LV systolic dysfunction. And there was a proportion of patients who required ECMO for support. This was another study of children that presented with heart failure in a diagnosis of COVID-19 versus MISC. This was a study of 35 children in Europe. Their inclusion criteria was fever greater than 38.5 and presenting with either cardiogenic shock or an LV ejection fraction of less than 50%. And they also had to have demonstration of an inflammatory state with a CRP of greater than 100. Their COVID history was documented in a number of different ways. There was 88% of patients were PCR positive, 86% of patients were antibody positive. There was 2 patients who were negative by PCR, but did have lung CT findings consistent with COVID. Their median age was 10, and there was no underlying cardiac disease in any of these 35 children. All of them required ICU admission. This graphic shows a representation of the clinical signs of MIS-C, and in red, they're pulling out things that are seen in Kawasaki disease, so the bulbar conjunctivitis, the red and cracked lips, the lymphadenopathy and rash, along with coronary dilations and pericarditis. But there are in black all of the other things that we don't typically think of as being associated with Kawasaki disease, notably the LV systolic dysfunction in 100%. But again, that was an inclusion criteria for this study and developing shock and VA ECMO. So these children, the 35 children in this study, their typical presenting symptoms included fever, weakness, and GI symptoms predominantly. There were 82% of them were admitted directly to the ICU, and the remainder were admitted to the floor and actually transferred to the ICU within 24 hours of admission. 80% of them were defined as being in cardiogenic shock on the basis of requiring inotropes, and 28% required VA ECMO for support. All of them had a severe inflammatory state with significant elevations in their troponins, BNP, D-dimer, CRP, procal, and IL-6. And in these patients, so that just to remind you that to get as an inclusion criteria, your EF had to be less than 50. So 28% of the patients had severe LV systolic dysfunction with an EF less than 30, and the remainder had mild to moderate dysfunction in the range of 30 to 50. But the LV dimensions were largely normal. Only 3 of the 35 patients had pericardial effusions, and only 6 of the 35 patients had dilated coronary arteries. They were treated with a variety of treatments, including IVIG, IV steroids, anakinra, and heparin infusions. These patients largely recovered their LV function. So recovery was seen in 71% of patients at a median of 2 days. And the remainder of patients that did not have recovery had just mild to moderate dysfunction with an EF of greater than 45%. And they saw no thromboembolic events. And the median ICU stay was around 7 days. So moving on to a case example of COVID myocarditis. This is from JACC case reports, and there are many similar type of cases that you can find in the literature, but not great studies, as these are all tend to be sort of one-off cases. But this is a case of an 18-year-old male who had no past medical history. He presented with cough, fever, fatigue, and myalgias. His blood pressure was normal at 120/70, heart rate was elevated at 110, and he had mild tachypnea with a respiratory rate of 22. Oxygen saturation was 94% on room air. His PCR was positive for SARS-CoV-2. His chest CT, as you can see here, showed diffuse peripheral opacities that are consistent with COVID-19. He progressed over the course of 3 days of hospitalization to severe hypoxemia requiring intubation. And he had a very severely elevated troponin and BNP, as you can see by those numbers, along with elevated CRP, fibrinogen, and CK. His EK showed sinus tachycardia with T-wave inversions, and his echo had diffuse hypokinesis with an EF of 30% and mild LV dilation. He required norepinephrine to support his blood pressure. He underwent cardiac MRI on day 7 that was consistent with myocarditis, which is being shown in these image series here. And he had a repeat cardiac MRI on day 14, which is the lower row. And he had rapid improvement of his cardiac function, and his clinical status was just supportive therapy. And by day 14, his ejection fraction by cardiac MRI was up to 54%. So to conclude, myocardial injury is common in SARS-CoV-2 infection in both adults and children, but myocarditis is relatively uncommon, and there are other disease mechanisms that appear to predominate, including the inflammation, cytokine storm, and microvascular thrombosis. In children, we see MIS-C rather than acute COVID-19 as a period of risk, but it is difficult to differentiate between MIS-C and COVID myocarditis due to the overlap of these two conditions. The treatments remain idiosyncratic and unproven, and other supportive therapies seem to be our best bets at this point in time. So with that, I'll hand it back over to Seda.
Thank you. It was a fantastic presentation, Liz. I guess there are no questions yet. I'll start with the first one. In the first article you presented, the New England Journal article, you mentioned that there is a discrepancy between the need of inotropic support and the level of LV dysfunction. Why do you think that is?
I mean, I think these patients are also being cared for in intensive care units, potentially with pulmonary issues or with more of a sepsis physiology. And so I think it's hard to pull out from this data, are these patients presenting more as sepsis and requiring inotropes for that reason, or are they requiring inotropes due to cardiogenic shock? And it seems like from that data that it would suggest that more of those patients in the New England Journal study were more being supported with inotropes due to more of a sepsis type physiology.
Great. We have a question. Thank you. So this is from one of our audience. Okay, great. Here you go. Can you hypothesize about the mechanism for the degree of LV dysfunction? That's one question.
You know, I mean, I think we see in myocarditis that patients can have a huge variety of presentations. So some patients with myocarditis with the same infection, when you look at sibling studies, can sometimes be much sicker than others. And there's certainly seems to be some genetic components, as there are some reports of twins both getting myocarditis or some family predominance with myocarditis. So there's probably a lot of other factors that go into this. And we know with COVID as well, the viral load that you receive may also affect how well you respond. But why some patients are developing this more severe myocarditis type of phenotype and others are developing more of an MIS-C or a generalized inflamed state, I don't think we know.
Great. Thank you, Liz. I think we have one more question, but I think that will be answered by Ingrid's presentation. It is, the question is, are there any specific recommendations yet for screening adolescent athletes following COVID infection? I think that's a good question to ask right now as we're moving to Ingrid. Thank you so much, Liz. Great presentation. So I am thrilled to introduce our next speaker, Dr. Inger Olson, a great colleague of mine. Dr. Olson is a clinical associate professor in pediatrics at Stanford. She's a pediatric cardiologist specialized in imaging, and she is also the director of our exercise laboratory. She's also heavily involved with medical education and leads the medical student cardiology clerkship program, as well as the pediatric residency cardiology rotations. And Dr. Olson will talk about a topic that is really dear to my heart, when to return to exercise after COVID. Inger, there you go.
Okay, thank you. And thank you, whoever asked that nice segue question. Okay. All right. So, and thank you, Liz, for the great discussion of COVID-19's effect on the heart. I am going to start by briefly going over some more of the studies regarding COVID and the heart, just to make some points, but none of them actually overlap. Then we're going to touch on some of the problems associated with risk stratifying patients for return to play, and then spend most of the time or a lot of the time of the talk on the risk stratification process itself. All right, so there have been studies in adults demonstrating MRI abnormalities concerning for cardiac injury in patients with COVID. So this is a study that looked at cardiac MRIs in college-age athletes with a mean age of 19 and a half years. These are 26 college athletes who had either asymptomatic or mildly symptomatic COVID infection, but were fully recovered symptomatically. The test was performed 11 to 53 days after the positive test, so during the subacute period. These patients all also had EKG and echo, which were normal, no troponin elevation, and by echo and MRI both, normal LV volumes and function. So they found 4 of the 26 patients had MRI evidence of myocarditis, and 2 of these also had pericardial effusions. Another 8 had late gadolinium enhancement concerning for fibrosis. I am going to point out this is a very small study with no controls. But this study demonstrated that cardiac MRIs performed in college athletes during the early convalescent period found signs of cardiac involvement in almost half of the patients, again, without controls. So this first study here is a review of 43 patients from multiple countries looking at the clinical characteristics of both asymptomatic and symptomatic patients. There were 158 patients less than 17 years of age. 36% of the symptomatic patients tested had elevated CKMB, and 64% of the asymptomatic patients tested had elevated CKMB. This other study is a meta-analysis of 20 studies, including 610 children, looking specifically at lab abnormalities in patients with both mild and severe COVID. So in this patient, out of 200 patients who had mild illness, 33% had elevated CKMB. So both of these studies demonstrated elevated cardiac enzymes in mildly symptomatic or asymptomatic children with COVID-19, as well as the more severely symptomatic. I'm actually going to skip this one because it just reinforces what Liz was saying, which is cardiac injury is common in patients with MIS-C. And then this is a large study looking at clinical characteristics of 651 patients admitted to the hospital in the UK, patients less than 19 years of age. This demonstrated that of the 37 patients who had MIS-C with cardiac testing, 57% of them had cardiac complications. Of the patients who had cardiac complications, 68% were antibody positive rather than antigen positive, indicating that the cardiac complications of MIS-C were more likely to occur in the subacute and convalescent patients. So what do we know? This slide represents what I knew at the time I started preparing for this talk. So let's fill it in. So the data demonstrates that most children with COVID-19 will be asymptomatic or mildly symptomatic. However, myocardial injury does occur. It's common in the MIS-C population, and evidence also suggests that it may occur in mild and even asymptomatic cases of COVID-19. MIS-C also frequently occurs late after initial infection, so an apparently recovered patient in the convalescent phase is still at risk. The underlying concern in clearing a COVID-19 patient for return to play is the possibility of myocarditis. I'm going to touch briefly on why exercise and myocarditis is such a concern. So there is a strong link between myocarditis and sudden death, especially during exercise. Exercise has been shown to increase viral titers, worsen cardiac function, and increase the immune response directed toward the heart. So when myocarditis is present, the risk of sudden death increases with exercise. And this risk does not necessarily correlate with the amount of inflammation. So a patient with perceived mild cardiac injury could be at the same level of risk as a patient with more severe disease. Now, what don't we know? Although there is clear evidence of abnormal cardiac testing in patients with COVID-19, the clinical implications are unknown. Transient elevation in troponin levels have been seen with bouts of exercise in otherwise healthy athletes. Athletes studied by MRI, pre, immediately post, and 1 week after an endurance race showed a mild decrease in RV function and an increase in troponin and BNP, all of which had improved at the 1 week follow-up. A similar study demonstrated a change in LV function. Also, evidence of non-ischemic myocardial fibrosis has also been found in otherwise healthy athletes. So there's no clear direct correlation between abnormal testing and clinically significant myocardial injury. And lastly, although complete or near complete recovery of cardiac function is frequently seen in the pediatric population, the long-term outcomes of patients with COVID-19 and or MIS-C is obviously unknown. So considerations for return to play. When considering return to play in a patient post-COVID-19 infection, the three main questions to ask are: how severe was the infection? When was the infection? And what is the sport or activity being considered? So how severe was the infection? A patient with a more severe presentation is more likely to have cardiac involvement. And more severe meaning sicker or with prolonged symptoms. While MIS-C can occur in patients with a mild initial presentation, it is at least less common. So these patients are considered lower risk. Since cardiac enzymes have been found to be elevated in asymptomatic or mildly symptomatic patients as well, all patients should be risk stratified. But the risk stratification does take into account the severity of presentation. Next question: when was the infection? So the main consideration here is whether the patient is still within the subacute phase when MIS-C can occur. The minimum duration of rest required after COVID-19 infection is 10 days after resolution of symptoms. So patients should not be seen for return to play consideration before then. Patients who present for sports clearance early after the required rest period are still within the subacute phase when MIS-C can occur. So these are patients that, even if they get cleared, should still be monitored closely. Outside the 4-week period after infection, the risk decreases substantially. So as Liz showed in her study, with the mean duration to presentation of MIC of 25 days, it can certainly still happen after that time. And then the third question: what is the sport or activity being considered? So in sports clearance, one size does not fit all. Older, highly competitive athletes who undergo rigorous training are at higher risk than younger patients who typically exercise recreationally and at lower intensity. However, an older athlete who participates in lower intensity sports may have a lower risk than a younger patient competing at an elite level. The main focus of risk stratification is the group of patients who are competing at high levels or exercising more vigorously, since it's assumed patients who are exercising at low or very recreational levels are at lower risk. In May of this year, the ACC Sports and Exercise Cardiology section put together recommendations for return to competitive athletes after COVID-19. The initial recommendations were for 14 days of rest after illness and for extensive testing even for mild illness. These recommendations were updated in October to include the revised shortened isolation period recommended by the CDC and to include less testing on milder cases due to the low yield that they had found in testing this group. So this is the one of the two major papers that I'll be referencing for the risk strategy for the return to play. This paper includes a section on high school athletes who they divided into two categories, less than 15 years and greater than 15 years. And the majority of the focus of this paper is on adults. An ACC expert analysis on return to play from pediatric cardiologist perspective was published in July. This groups pediatric patients into less than 12 years and 12 years and older. So the pediatric cardiologist perspective paper is more relevant to our population, but the adult paper has the most up-to-date guidelines. So let's get into risk stratification. Regardless of age, both papers agreed that patients who remained asymptomatic or had mild symptoms were low risk, and that after the self-isolation period, no further testing for risk stratification was necessary. Mild illness here is defined as no fever and less than 3 days of symptoms. And this also assumes no clinical or lab findings suggesting myocardial involvement. The rest period is 10 days after resolution of any symptoms. The pediatric paper actually says 14 days, but again, this was published before the CDC guidelines were revised. So I am assuming 10. Resumption of training or sports should be slow and graded. And if new cardiovascular or potential MIS-C symptoms develop, then testing for risk stratification is recommended. All right, so moderate illness is defined as more than 5 days of symptoms, still not hospitalized, or with any clinical or lab findings concerning for myocardial injury. Children less than 12 years of age who are planning on recreational sports can be cleared for a slow return to exercise, again with the caveat that they have additional testing if any new symptoms occur. And that's a common theme throughout the paper. If, however, a patient in this age group is planning to resume high intensity or competitive sports, or if they had any cardiac symptoms during the acute phase, then consideration should be given to treating them like the 12 and older group. So for patients who are 12 years or older and returning to competitive sports, the convalescence period is slightly longer, 10 to 14 days. After that, a patient should be evaluated by a pediatrician, which is not necessarily advocated for in the milder groups. At a minimum, the patient should have a screening EKG to look for signs of myocarditis. And thank you, Liz, for going over those. If the ECG is normal, the patient can be cleared for return to play. If, however, the ECG is abnormal, they should be referred for formal evaluation by a pediatric cardiologist. And this slide has an or, because for more concerning symptoms or higher intensity exercise, the pediatric paper suggests following the guidelines from the adult paper for this group of kids greater than 12 years of age. So this is a place where a lot of judgment calls come in for how intense do you think the exercise is, while they had moderate symptoms, how bad were those moderate symptoms, how long were those moderate symptoms. If you're less concerned, you can follow the pediatric path. If you're more concerned, go this direction. So these are the recommendations for returning to play in competitive high school athletes from the sports cardiology group paper. The adult guidelines are much more detailed. They rely much more on testing than pediatric populations generally do. For patients less than 15 years of age, including the 12-year-old we just bumped up into this group, the only difference from the pediatric recommendation really is an added echo and high sensitivity troponin if available. There is no reference for what if it's not available, and my assumption is if you are concerned, you can do a troponin, or you can ask your friendly heart failure doctor. The reason for this additional testing is the adult group does not feel that an ECG alone is adequate screening for myocarditis. Again, this is looking at it from adult population. For patients who are 15 years or older and playing high intensity or competitive sports, they actually get bumped up to the recommendations for adults. Before we go there, I want to point out the other feature of this slide, which is the final common pathway for patients who have new cardiovascular or potential MIS-C symptoms after returning to play, regardless of their original status. You can see from this recognizably busy graph that even asymptomatic patients, after return to play, if they develop concerning symptoms, everybody goes to this point. So evaluation with an ECG, troponin, and echo if not already performed, and then an MRI if any of these tests are concerning. Or if the patient previously already had the clinical evaluation with the ECG and echo, then you can go straight to MRI. If there is MRI confirmed evidence of myocardial injury or edema or a high index of suspicion, then return to play guidelines based on myocarditis should be followed. And we will get back to those, but I'm going to touch first on the guidelines for adults returning to competitive sports. And this is for that group of older 15 and older who were bumped up to the adult guidelines. For adults and older teenagers with moderate symptoms, comprehensive cardiac testing is recommended. So not a ton of difference from the pediatrics other than going straight to the additional testing. If those test results are normal, then you can return to play. And if not, then consider repeat testing. And this is based on the question of if you have an isolated troponin, is it due to the fact that you're an athlete, or go straight to MRI. If the MRI is abnormal, again, follow the return to play guidelines based on myocarditis. If the MRI is negative, then based on the abnormal testing and the concerning symptoms, other things to consider would be exercise testing and ambulatory rhythm monitoring, just to continue risk stratifying this patient. And then the last group is the patients with severe illness. The severe illness is fairly straightforward, but there is some diversion between the two papers. A large part of this may be the definition of severe illness. So in the pediatric patient, severe illness was defined as hospitalization, abnormal cardiac testing, and or MIS-C, so basically presuming cardiac injury. The adult paper classifies severe illness as hospitalization and protracted symptoms, I believe it was more than 14 days, but not with presumed cardiac injury. So it makes sense to me to reclassify the pediatric flowchart here as presumed cardiac injury and the adult flowchart as no presumed cardiac injury, both for patients with severe illness. So if cardiac injury is presumed, then testing for myocarditis should be performed and the patient should follow myocarditis guidelines for return to play with the assumption that myocarditis is present. So testing is not recommended just to decide whether you're going to follow the myocarditis guidelines in these patients. For no presumed cardiac injury but severe illness, there is still extensive testing, but the second tier of the test is optional depending on the level of concern. So at a bare minimum, the EKG, troponin, and echo, but if these are normal, then whether you do the exercise test and the MRI is optional. So I want to touch briefly on the myocarditis return to play guidelines, since they are referenced extensively here. The main thing is athletes with probable or definite myocarditis should not participate in competitive sports while inflammation is present. Before returning to competitive sports, athletes should undergo additional testing listed there, no less than 3 to 6 months after the initial illness. So myocarditis return to play says you need to be off exercise for at least 3 months before having additional testing to decide whether to return to play or not. Obviously, that would be under the care of an experienced pediatric cardiologist. The additional comment under myocarditis return to play guidelines is that athletes can resume training or competition if they meet all of these criteria, including ventricular systolic function normalizing, normal markers of myocardial injury, and absence of arrhythmias. One last point made by the pediatric paper, because of the inability to detect all cases with myocardial injury, based on the questions of whether the lab findings are relevant, whether the patient is outside of the risk period for development of MIS-C, they encourage youth sports centers and high school centers to reevaluate their emergency response preparedness, including availability of defibrillators, CPR training, and access to emergency medical care. This is just highlighting the problem of the unknown long-term result. So summary points. Most pediatric patients should be able to return to play without extensive cardiac testing, as long as they are fully recovered and have no evidence of myocardial injury. Return to play should be gradual and after an appropriate period of rest following recovery. And despite the appearance of full recovery, children should be monitored carefully during at least the first month post-infection for any new symptoms concerning for cardiac injury or the development of MIS-C. And that is it.
Thank you, Inger. Excellent review. We have 7 minutes. I see some questions trickling in. There is, and then I think Alan also has some questions. Let's see if we have time. So the first question is, do findings of COVID-19 LRI, which can, what is this? Alter the cardiac algorithms, such as chest CT, which can dissociate from clinical symptoms and severity. I would think this complicates things and might call for more cautious return to play. What does LRI stand for?
Lower respiratory infection.
Oh, okay. Cardiologist here. Okay, yeah. Inger or Liz, would you like to take the question?
Yeah, so I would point out that all of the algorithms that we were looking at are all specifically focused on the heart. I think definitely if you have severe respiratory illness, I think that would require further respiratory evaluation and an additional decision tree on that fork.
We also have one remaining question from the last session. Do the therapies associated with myocarditis, IVIG, and steroids work as effectively in COVID myocarditis?
I think we really don't know. It's definitely what people are using. The data around IVIG in myocarditis is actually terrible, but we all do it anyways. And so it's usually supportive care and offloading the myocardium and supporting with ECMO if you need to in severe cases. And so for COVID myocarditis, there's so few and they're so scattered. I haven't seen, a good data that supports a treatment algorithm in pediatrics, but definitely what is being done is very similar to what's being done for our standard myocarditis. So IVIG, with the addition of anakinra being, I think, the one medication that you hear mentioned a little bit more frequently in the treatment of COVID myocarditis, and that's in part related. There's increased inflammation and IL-6 and other things that suggest that maybe it's more inflammatory, and that's why anakinra has been used before.
Thank you. We have one comment here from actually Dan Bernstein. I'll give out his name here. I worry that in any competitive sport, especially at the high school level, the idea of a gradual reintroduction into high exertion activities is really difficult. Peer pressure and coach behavior often get in the way. I agree. Sometimes it's very hard to train the coaches and the peers. And
we get a lot of that on the cardiac side too, when I screen patients for cardiomyopathy. And I think that that's where using your cardiology colleagues to meet with families and discuss the risks is a reasonable option.
Exactly. Inger, any comments on that?
No, I completely agree. And I think other than educating the public on the risks of myocarditis and exercise, I don't know, what can be done to change that culture.
Yeah, very hard. We have one more question from the September JAMA article. It appears myocarditis or cardiac abnormalities are common following even asymptomatic or mild COVID infection in athletes, even with normal EKG, echo, and troponin. Does this mean a routine peds cardiology consultation with EKG and echo would be insufficient screening? Very good point.
Trying to read this.
I mean, I think it's hard. I mean, I don't think we have the bandwidth to screen every patient with COVID with a cardiac MRI, certainly. And, a cardiac MRI is not minimal procedure either for children under the age of 12. And often patients require sedation. So I think we're going to have to think about that all cautiously. Interestingly, at least in my mind, is the patients who have COVID myocarditis and MIC, some of these elevations in the troponin and BNP are really through the roof, and they're much more out of the range that you would see for other conditions. So it may be that you can use the lab test and sort of the inflammatory state as a way of sort of helping you risk stratify without necessarily adding in addition the cardiac MRI.
Yeah, and I would add to that about the MRI. That's where there's been a lot of concern about, especially in athletic patients, relying on MRI in isolation because it's not clear that findings on MRI translate to clinically significant abnormalities. The original adult recommendations required MRI much more heavily, even in the mild patients, and since have backed off and said, use it based on other findings.
Can I just build on that? And I mean, it seems like with 15 million cases in the U.S., many of them having been asymptomatic, it seems like if this sort of return to play post asymptomatic sudden death thing was an issue, we'd be seeing it. And to my knowledge, we really aren't. So how can we, and that to me gets at that maybe we're finding things that are interesting, but perhaps not that clinically relevant with some of these cardiac MRI studies.
Ellen, I think it might be skewed because of COVID, though. A lot of people are not back to their routine exercise, even athletes. They're either not allowed or there are restrictions. I wonder whether that's why we're not seeing it. Hard to tell, obviously.
Yeah, it's obviously very small numbers. Also, what raised the interest in a lot of these studies were the sort of high-profile athletes who were found to have myocarditis post-COVID. So there definitely are real cases of myocarditis, but that's the question: is how many are real and how many are not. If you're a parent, then your patient, your child, if your child dies, that's the only one you cared about. That's the problem.
Do we have time for one more question, Alan? Yes? Okay. Are there recommendations about arrhythmia monitoring post-COVID myocarditis with Zio or Holter?
I would say that if you had true myocarditis, you would follow your routine myocarditis screening and exercise restriction, which we often exercise restrict here for 6 months post myocarditis, and would do screening Holter or Zio patch looking for arrhythmia. So I think that probably COVID myocarditis, we would just follow a similar protocol for that.
Fair enough. Thank you, Liz and Ingrid. This was a great session. And Bradford, you're still on. I think we're out of time. Alan, do you want to have any?
I just want to echo the thanks. Rajni, thank you for coming back on too. It was really informative. I learned a lot, and I think it's helpful to see those guidelines. So
great. Thank you, everyone.
Thank you all very much.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.